Yeah, so ASCO this year had a lot of GI oncology focused abstracts that were actually meaningful. Of course, there was a lot of things happening, but GI had a role to play. And I'm a GI oncologist. That's my practice of interest. I've been doing it for about 15 years now. So I was excited to see some of those results coming up. So there was basically this wave of transformative data across many GI malignancies, kind of showing a shift in therapeutic standards, particularly in gastric, colorectal, esophageal, and there's some glimpse of benefits in pancreatic cancer. So more to follow on those ones. Matterhorn is basically a randomized phase 3 study of durvalumab plus what we use usually a FLOT in the perioperative setting for resectable gastric and gastroesophageal junction cancers. So as we know, 1.2 million people die with cancer and gastric cancer and esophageal cancers in 2025. And FLOT, something that we had been using often, which is fluorouracil, leucovorin, oxaliplatin, and docetaxel for patients with G junction and localized gastric cancer. But even with that regimen that had changed the paradigm a few years ago, we still have patients have recurrences. So the idea here is to add in an anti-PD-1 therapy to chemotherapy may improve the outcomes in this population of patients, as we saw potentially benefits in the static setting. So the idea here was to use this clinical trial to show it into patients with resectable gastric cancer, gastroesophageal, being randomized to basically get in a placebo plus FLOT versus durvalumab plus FLOT. Durvalumab is standard dosing, 1,500 milligrams every 4 weeks. And they were randomized 1-to-1. So it was a large study. They included stage 2 to stage 4A gastric and GEJ junction adenocarcinomas with no prior therapy, of course. And about 948 patients were randomized to get 2 cycles of durvalumab plus FLOT or the placebo and FLOT, and then get surgery. And after surgery, they went up to adjuvant up to a year to continue 2 cycles of durvalumab FLOT. And then after they do maintenance, about 10 cycles of durvalumab every 4 weeks. And the idea was to analyze, event-free survival, and the secondary endpoints were OS and pathologic complete rate. So basically checking how much response has been to the treatment as a whole. And interestingly enough, this Matterhorn study stood out as a potential real practice changer because it showed that the addition of durvalumab with perioperative FLOT chemotherapy improved event-free survival, also pathologic complete response rates, and it didn't really add a lot of toxicity or surgical delays. And so not only like it also improved the event-free survival at 2 years versus chemo alone. So this basically paves the way for immune therapy to be integrated earlier into the continuum of localized disease. And if we look at the numbers, so basically the median EFS was actually not reached in the arm which was FLOT plus durvalumab versus the placebo plus FLOT, which was 32.8 months. And hazard ratio was pretty good, was like 0.71 with a p-value was statistical significance. And the median overall survival is interim, so we still are going to read out in the future. But what we see as of now is that it was not reached for durvalumab, but it was 47.2 months with the placebo arm. So in response rate, as we alluded earlier, was 19% for durvalumab and 7% for the placebo arm. And very statistically significant as well. So what we see here is that this is probably going to change in the future, and we expect probably some submissions to the FDA and whatnot to get these patients treated as well with this regimen, potentially NCCN guidelines. We'll see what happens with the guidelines, but I'm seeing this as a really new treatment option for our patients to optimize their outcomes around surgery in resectable disease. The LBA late-breaking abstract 4112 was basically this a study for assessing in HER2 expressing gastric cancers if the use of this immunoconjugate called Disitamab Vedotin added on with a checkpoint inhibitor, in this case toripalimab, plus chemotherapy was used in patients who were basically in first line expressing locally advanced metastatic gastric cancer, GE junctions, adenocarcinoma and checking on how the overexpressing versus the median or low expressing patients will respond to therapy. So the results are interesting because we know immunoconjugates work, but we always are curious to see if the response rates are going to be holding up. So what we saw overall is that these Disitamab Vedotin triplets, which is now a triplet, and we're using now multiple drugs, show superior response rates and efficacy versus control in both HER2 overexpressing and in HER2 median and low gastric and G junction cancer. So basically, and this is not definitive. This is a phase 2 segment of a phase 2/3 trial evaluating this ADC plus toripalimab and chemo. But what we know is that the response rate was very high, was about 82.4% on the triplet versus the control arm, which was 68.8%. The median PFS was not reached at the time versus 14.1 months with a very good hazard ratio, 0.59. And in the HER2 median or low cohort, we also saw responses. So kind of like telling us that, as we all know, not all HER2 are made equal. And even in the HER2 lower expressors, there may be some signal of responses. It was 72% response rate on the triplet versus 47.8% of the toripalimab plus CAPOX. And the PFS was also superior in the statistical difference here. So side effects, of course, can occur with these drugs. So the most common side effects were diarrhea and decreased blood cell counts. So signal still early, and it's telling us that we should continue to optimize in the HER2 setting and see what opportunities we have with patients with low expression of HER2 but still present. And it's a novel ADC PD-1 combination, and so it's something that we didn't try before. And it's helping us to maybe optimize the care for those low expressors of HER2, but still present there. Of course, we need the confirmatory data of the phase 3. We also probably want to understand further, maybe with other things such as circulating tumor DNA, or like really going into in depth about the how low the HER2 can be for those patients to be benefiting from this. And looking at now more meaningful outcomes, as these are metastatic patients, we want to see overall survival answers as well for those cohorts. So very promising based on response rate, but we know those are surrogate endpoints and not necessarily definitive endpoints for us to feel that this is a landscape changing drug. But interesting effort of combining now an ADC with a checkpoint inhibitor, which is something that is now emerging as a potential model for research. Probably the role of digital pathology to give us very pinpoint assessments of HER2 are going to be crucial for this. And also checking the microenvironment in terms of the lymphocyte infiltration and how that plays a role by adding on the checkpoint inhibitor, because we know that that probably has a major impact of why these patients are responding compared to others. So having those immune scores aligned and checking also maybe circulating tumor DNA would be helpful. So having not only the checking what's happening dynamically on the ctDNA, but checking as well if there's any microenvironment changes that are more favorable or not favorable for the responses of the combinations. Yeah, so the ATOMIC trial is a study that we have been all waiting for, for come to fruition and results. We know in colorectal cancer, there's a subset of patients with mismatch repair deficiency, or we call MMR deficient colorectal cancers, not only because they have history of Lynch syndrome, but also they happen somatically that those MSI high features appear. And there was aimed to answer the question. Okay, we've seen that mismatch repair deficiency helps patients in the metastatic setting. Is this going to help patients in the adjuvant setting, as we have a number of patients that actually have those mismatch repair deficiencies present In the past, that was considered actually a reason not to give adjuvant treatment in certain patients. So the idea here is like, can we use this in a stage 3 mismatch deficient colorectal cancers, adding FOLFOX, modified FOLFOX, which we all use often. Of course, currently we also use, capecitabine and oxaliplatin for based on the idea collaboration data. But the idea was to use something that is used everywhere. So it was atezolizumab added to modified FOLFOX6 to assess how is going to be impacting the risk of recurrence for patients with stage 3 mismatch deficient colorectal cancer. So great effort because, adjuvant patients are not easy to follow. So in terms of the study design and the outputs of the ATOMIC trial, so there was 712 patients. There was randomized 1-to-1 to receive FOLFOX plus atezolizumab 6 months, followed by atezolizumab for 6 months monotherapy. The control arm was FOLFOX alone, which is what we used to give for most of my patients. And then the key results were based on this endpoint on disease-free survival. So the 3-year disease-free survival was 86.4 months for the atezolizumab arm versus 76.6% on the chemotherapy alone. The hazard ratio for DFS was 0.5, so basically decreasing by half the risk of distant recurrence or death in this population of patients with a p-value of less than 0.001. And at the same time, the safety, the grade 3 side effects or more was 71.7% with atezolizumab versus 62.1% of chemotherapy alone. And most of those adverse profile was basically consistently with what we see in patients with checkpoint inhibitors. So all put together, it just showed us that atezolizumab plus FOLFOX significantly improved DFS in stage 3 mismatch repair deficient colorectal cancer. And the conclusion was to establish this as a new standard of care in this biomarker-defined population. But this is transformative because now we know for that when you have these specific, molecular defined, features in your cancer, we can say that this combination is much better than what we used to give to other patients as well. So it's now a new standard of care and something that we should be offering to all of our patients, and a new paradigm shift in the curative intent management for these patients with mismatch repair deficient colorectal cancer. So we always want to achieve cures, as many as possible, and the ATOMIC trial gave us that opportunity for many more patients with the addition of a checkpoint inhibitor for adjuvant setting in these patients. The other things that are going to change in the future is we're seeing more and more testing on the mismatch repair deficiency for all of our patients with colorectal cancer in the earlier settings from other studies that had been presented as well. And some of those patients are now not even getting chemo or radiation or surgery because of the inclusion of checkpoint inhibitors earlier before surgery takes place. So now the question is, are the new studies going to be accounting for that? Because a number of patients will be potentially be given this combinations or even just checkpoint inhibitor alone, or maybe doublets of, CTLA-4, PD-1 combinations. And now many of them may not even require adjuvant treatment. So the landscape is still opening up, but it's just telling us that this unique population of mismatch repair deficiency is still up for optimization and changes in the paradigms as we have early wins across different settings. So now comes the point that we need to organize the whole data sets and say, okay, if the patient is going to receive checkpoint inhibitor earlier, how is that going to modify the checkpoint inhibitor later if the patient ever gets to surgery or not at all? So it's a lot of modality changes that are currently being in flux because of these breakthroughs. Yeah, so the CheckMate 577 is a study that we have already got results prior, but we wanted to get an overall survival update. So just as a reminder, this was a global randomized double-blind placebo-controlled phase 3 study of adjuvant nivolumab versus placebo in resected esophageal GEJ junction cancer with residual disease after neoadjuvant chemoradiation and surgery. So the idea is to see, okay, if we had these patients who have received multimodality treatment already, Is the addition of a checkpoint inhibitor in the adjuvant setting superior, or at least safe and better than what we do now, which is sometimes just giving the chemotherapy alone? And this study accrued 794 patients, randomized 2 to 1, stage 2 and 3 patients who underwent multimodality treatment. And the key results based on disease-free survival was median DFS of 21.8 months with nivolumab versus 10.8 months with placebo. The hazard ratio was 0.76. The median overall survival was 51.7 months with nivolumab versus 35.3 months with placebo. The hazard ratio was 0.85. Even though the p-value was not statistically significant because it was 0.1064, the 5-year overall survival rates were 46% on the additional nivolumab versus 41% on the control arm. The other output that came out was the distant metastasis-free survival, as these patients underwent multimodality treatment with curative intent. We wanted to look as well for not having metastases as well. So the median distant metastasis-free survival endpoint was 27.3 months with nivolumab versus 14.6 months with placebo, with no major changes on the safety profile. So it just kind of told us that all these results combined, adjuvant nivolumab really significantly improved disease-free survival, which was the primary endpoint, and distant metastasis-free survival in patients with residual disease, with a numerical but non-significant trend favoring OS. And because of that, nivolumab still remains the only approved immunotherapy in this setting, and gives us reassurance that when we give patients with residual disease nivolumab, we are improving disease-free survival for these patients. So in the metastatic setting, HER2 targeting took center stage, as we've been talking as well. So DESTINY-Gastric04 trial confirmed basically that Trastuzumab Deruxtecan is an option for second-line standard HER2 positive gastric GEJ junction. So we know based on all these DESTINY studies, right, that they're trying to look for efficacy and benefits of Trastuzumab Deruxtecan, which is an ADC that we use very often in many of our patients. The idea here is to see if we can move it a little bit earlier in the treatment paradigm. The DESTINY-Gastric04 trial was this global open-label phase 3 study of T-DXd versus what we use in our patients in the second-line setting, which is ramucirumab paclitaxel very often. In HER2 positive, unresectable or metastatic GEJ junction gastric cancer after the patient has been progressing on trastuzumab treatment. They randomized 1-to-1, 494 patients. The median overall survival was what they wanted to check. And the key results of the study showed that the median OS was 14.7 months with the T-DXd arm versus 11.4 months on the ramucirumab paclitaxel arm. A hazard ratio was 0.7 with statistical significance as well of a p-value of 0.0044, basically establishing this superiority in terms of median overall survival. In terms of median PFS was 6.7 months on the T-DXd arm versus 5.6 months on the ramucirumab paclitaxel arm. Hazard ratio 0.74 and also statistically significant of a p-value 0.0074. In terms of response rate, confirmed was 44.3% on the T-DXd arm versus 29.1% on the RAM paclitaxel arm. So it's just telling us that there's also not only superior progression-free survival and OS, but also response rates in those patients. And probably a reason why these patients had the superior response. The disease control rate was 91.9% on the T-DXd arm versus 75.9% on the RAM paclitaxel. In terms of safety, we already use all these medications in the standard of care setting. The ILD pneumonitis was 13.9%, mostly was low grade, but of course, a side effect that we always need to be in the lookout for all of our patients and part of our workflow and protocols. In all summary, basically, is telling us that in HER2 positive, following trastuzumab treatment, we can consider T-DXd as the new standard of care in this setting, given improvement in OS, PFS, and also response rate in the second line. I think that in light of other studies that we have been discussing, the liberating abstract of this Disitamab Vedotin, the question now is going to be, are we going to be looking into HER2 low as well for these patients, and how the checkpoint inhibitor is going to also impact the paradigm and how we approach this combination. We still have more data to follow in terms of ADC use, which ADC is going to come ahead, and not necessarily just ahead, but if it's a combination, the way for us to tailor the treatment for these patients better, and of course, using biomarkers, as we mentioned earlier, like ctDNA, digital pathology tools, and microenvironment assessment to really pinpoint who benefits the most from either single agent ADC versus combinations. Yeah, so pancreatic cancer is the most difficult to manage of all GI malignancies, not only because of, we don't have too many options, but many phase 3 studies have unfortunately not given us good answers in how to manage these patients better. So any new drug that comes up, and particularly with the ADC upbringing, I think is something we always want to look into. So biomarkers are not really that frequent in pancreas cancer. So in this particular case, we're looking for the CEACAM5, which is, as CEA, as we know, the cancer-embedding antigen, and we're looking at the matrix and see where that expression is happening. And pancreas cancer is one of those populations that, particularly in the heavily pretreated population, can be leveraged to target. So this phase 1 study is using this anti-N256 glycosylated CEACAM5. So I know it's a long word, but it's just the mechanism of what is targeting. And the drug itself is called EBC129. And the idea was to evaluate in heavily pretreated pancreatic ductal adenocarcinoma patients the potential response rates of these patients and other outcomes. So the study was at the end is low, is 21 patients with 20 evaluable overall, and median 3 lines of prior therapy, which is heavily pretreated patients. But the key results overall showing an objective response rate of 20% overall, with 25% at a higher dose was 2.2 milligrams. The lower dose was 1.8 milligrams per kilogram. So the overall response rate was fairly stable regardless of the dose. The disease control rate was 71.4%, which is very interesting and something that is probably attention calling, because we don't see that kind of response rate or disease control rate in patients with heavily pretreated pancreatic cancer. The median PFS was still early, so measuring weeks, so 12.9 weeks. But what we're seeing here is, if we look into months, right? It represents, we're seeing PFS that goes into the 3-month range. In pancreatic cancer, heavily pretreated, this is something meaningful in terms of signal. And it was very manageable in terms of the safety as usual, when we want to highlight safety as well in these ADCs. So what we call out of this is, EBC129, it's promising in terms of early activity, managing safety profile that is, signal calling for heavily pretreated pancreatic cancer, and probably supporting further development. This was FDA Fast Track designation granted in May 2025. So we're going to probably hear more about these agents and hopefully many more agents in this setting. So more to follow on the ADC and pancreatic cancer saga. In alignment, well, with this year was all about, technology, AI. The ASCO's 25 team was driving knowledge to action. And the idea was to contribute to the global conversation in digital innovation in oncology through a couple of platforms. So the first, we had a session that was an ASCO ESMO joint session on biomarker-driven therapeutics. And the idea was to translate innovation into practice. Uh, Looking at the landscape of research in Europe and the United States and see how we can leverage digital tools, technologies to optimize biomarker testing for many more trials, and how we can revolutionize or transform as a whole the research delivery for patients, being very patient-centric. So as part of this effort, I presented how AI enabled pre-screening hubs can operationalize real-time clinical trial matching and biomarker testing at scale. So my talk emphasized basically a patient-centric, what we call hub and spoke model. That is also, we call it like click and mortar, right? Like a hybrid approach where patient is digitally enabled, but then they can get treatment at the point of care or close to it by leveraging these tools. And we want to integrate next generation sequencing, electronic health record data in real-time acquisition via FHIR standards, and real-world data to really democratize access to precision medicine, particularly for underserved populations. As we know, many patients, 91% of Americans live within, 30 miles of either diagnostic center or a pharmacy. So can we leverage these opportunities to optimize clinical research by getting the patient more decentralized and hybrid these clinical mortar clinical trials in oncology? So this effort is ongoing, and ASCO and ESMO was committed to continue these efforts, and that was part of the discussion. And in complementing all this, we were called upon to co-author a chapter in the 2025 ASCO educational book, basically titled Driving Knowledge to Action, Building a Better Future where Artificial Intelligence Enable Multidisciplinary Oncology. So free for everyone to access and read. Is basically exploring how AI is reshaping cancer care across specialties, from radiology to pathology to radiation and medical oncology. We're also addressing what we call as critical challenges because of bias, data privacy, explainability, and global equity, as we want this to be a whole global effort. So we want to align anything that is actionable strategies to ensure AI-driven oncology not only is more precise, but also more inclusive, ethical, sustainable, and in all over the world, and showing how we are using AI now to optimize the patient experience and to optimize our ability to deliver care better and focus on the patient. So that centricity of the patient and using the AI tools has been the major focus of what we're trying to accomplish during the meeting. We know that AI is taking us by storm, but also multimodality, how we're using biomarkers better, and the role of ADCs and immunotherapy. So not only we're learning, how to incorporate these technologies to give us better insights into early lines of therapy and molecular niches, but also how there's new disruptors in the space using ADCs in combination. And interestingly, answering questions that we didn't have before using bigger populations. So, for example, the role of chronoimmunotherapy, where we have now a phase 3 clinical trial that showed that giving immunotherapy before 3 p.m. Almost doubles the survival of patients, right? So just practical questions, but they will only come from data collaboration and understanding the whole spectrum of the disease and how this interacts with the microenvironment, with the molecular changes and the treatments that we're giving to our patients. So I'm excited about the future in oncology and how we're making strides in advancing care, and happy to be part of the conversation and discussing this with everyone here.